I'd like to begin by acknowledging that the lands we meet on today are the traditional lands of the Kaurna people and that we respect their spiritual relationship with country. We also acknowledge the Kaurna people as the custodians of the Adelaide region and that their cultural and heritage beliefs are still as important to the living Kaurna people today. I'd also like to pay my respects to other cultural lands that you might all be meeting on today virtually. So for those of you unfamiliar with CEIH, or the Commission on Excellence in Innovation in Health, we're the lead agency for innovation in healthcare in South Australia, and our role is to bring consumers, clinicians and other collaborators together to work towards the vision of better healthcare for all South Australians. To do this, we work through a portfolio of different areas in order to address that vision. So we have our partnerships portfolio, our patient reported measures area, clinical informatics, innovation, and of course, clinical networks. So our clinical networks is one of the key reasons that you're here today. So the statewide clinical networks are groups of health professionals, health service organisations, consumers and carers that all have an interest in a specific health area, and they work collaboratively with the goal of clinical service redesign for better healthcare. These networks operate across the continuum of care, so including private and public healthcare sectors, which of course includes our local health networks. The statewide clinical networks, they work to identify and collaborate so that they can resolve those strategic system-wide problems so that we can work towards those improvements in health outcomes for South Australians. Each network has a clinical and/or consumer lead and a steering committee which develop the vision, goals and work program for the network. So there are 8 statewide clinical networks you can see up on the screen here. And today, obviously, we're here to hear from the Surgical and Perioperative Care Network. And so just a little bit about the statewide clinical network conversation series. We're really pleased to bring you these. We've had one on each of our clinical networks, and I'll show you the schedule in a moment. They're on Thursdays at 1 o'clock and they're online whenever, which means we take this recording and we'll put it on our website, which allows you to share this with colleagues and review other presentations that you may not have made it to. The series has been running since October and finishes up mid-December. And it really provides that space to explore each of the clinical network and also have a Q&A session afterwards. So here's the conversation series program. We are 5 deep. So we have today the surgical network and then the urgent care and cardiac care networks in the following 2 weeks. So in terms of a little bit of housekeeping, as I mentioned, the presentation will be recorded and we'll stop the recording for question time. Please remember to keep your mics on mute. When you have questions, save them till the end. And I'm going to stop sharing screen and hand over to my colleague Phil, who'll introduce himself. Thanks, Phil.
Thanks, Nadia. I'm hoping that I've been able to share my screen correctly. Well, I guess we'll see in a minute. I wanted to add my welcome to that of Nadia and yeah, basically welcome you to the Commission on Excellence in Innovation in Health conversation series. And as Nadia said, we're focusing on the statewide surgical and perioperative care clinical network. I also just wanted to say how impressed I am that you've been able to stay awake today after you all watched the Socceroos progress through to the round of 16 in the World Cup soccer. So I was up with you, and if you're nodding off to sleep, I hope that I don't finish you off, and I hope that you're interested enough that you'll be able to ask some questions at the end. So again, yes, I'd like to thank everyone who's joined us online. I hope that this time will enable you to understand a bit more of who we are and what we currently do. I also hope it will encourage you to become involved with the network's activities and to perhaps suggest future initiatives. And finally, I hope it will help you to see where the statewide network sits in the broader SA health system and feel confident to utilise us as your first point of call for any issues, interventions or innovations that you wish to address in the areas of surgery and perioperative care. By way of introduction, my name is Phil Worley. I have the privilege of being the inaugural clinical lead for the statewide surgical and perioperative care clinical network. And briefly, by way of introduction, I've been working in the SA health system as a doctor since graduating in 1988. Initially, I trained as a procedural GP with special interests in GP obstetrics and surgery. After spending some time training in the UK, I initially returned to practice as a rural GP surgeon in the Clare Valley, which was both idyllic and demanding. I soon discovered that I wished to undertake full specialist training and returned to Adelaide to complete advanced general surgical training over the next 6 years. This included a wonderful rotation to Darwin and another stint in the UK. Upon receipt of my surgical fellowship in 2000, I was fortunate to gain a consultant position at Modbury Hospital, where I worked for 18 years before transferring to Flinders Medical Centre and Noarlunga Hospital 4 years ago. During this time, I've been able to also practice in both the Barossa Valley and Mount Barker and to gain a good overall picture of surgery in South Australia. I was also involved in the medico-political sphere of surgery, serving on the Royal Australasian College of Surgeons State Committee for 9 years, including 2 years as the chair of the committee. This gave me even more insight into the successes and failures of surgery across the SA health system. It was a demanding time, especially during the first year of the COVID pandemic. When the position of clinical lead for the newly formed statewide surgical and perioperative care clinical network was advertised, I felt that I'd been fortunate to gain experience in many of the areas that seemed to be required for the role. I didn't actually expect to be appointed to the role, but have found it to be both challenging and rewarding over the past 2 years. And as you've already heard, the surgical and perioperative network is one of 8 current statewide networks. Anyone who either delivers or receives surgical or perioperative care across South Australia, both metropolitan and regional, public and private, are included as members of this statewide network. From this, you can see that many of you joining us here today are members of the network and should feel able to contribute to its progress and success. My first task as clinical lead was to appoint the steering committee to set the goals of the network and to be involved in undertaking and facilitating the work required to achieve these goals. I was blessed with a large number of applications from across the full width and breadth of the surgical and perioperative fields. I feel we've been able to gather together a great mix of talents and experience covering a very broad range of the SA health system. We have been meeting as regularly as COVID would allow for the last 20 months and have been able to achieve a good deal of progress. I wish to thank every member of that steering committee for their hard work and contributions to the network's progress. The underlying objectives of our network are outlined here. Of great importance is the desire to replace what we often encounter at the moment, cross-network competition, with what we see as essential for success, that being cross-network collaboration. The current areas of focus for the network are at various stages of development, and I'd like to briefly show you where we're up to and perhaps where you may be able to contribute. Firstly, emergency surgery. After bringing together representatives from all metropolitan public hospitals to, for the first time, agree on definitions surrounding emergency surgery, the clinical informatics team at CEIH was able to develop a computer data model to interrogate in real time the levels of capacity and demand surrounding emergency surgery in our metropolitan hospitals. What we found was that actually only 75% of patients underwent their emergency surgery within the clinically recommended timeframe. Also, it was shown that a very conservative estimate of 35 beds per day were being occupied by patients who had already waited more than 24 hours after the recommended time for their emergency surgery. By extrapolating back from this, it can be seen that these beds are being blocked and they will contribute to our current ramping issues. The Health Minister is aware of these issues and is supportive of the network leading the way in trying to find a solution. This will involve a group of surgical and perioperative clinicians investigating alternative models of care and assessing if there is a different way for us to do business in South Australia when it comes to emergency surgery. We also know that emergency surgery and elective surgery frequently impact on each other. So a solution to the mismatch in capacity and demand for emergency surgery will inevitably involve dealing with elective surgery pathways and service provision as well. A horizon scan of the best performing models currently in use, both nationally and internationally, will inform the discussions of this group, and I look forward to being able to make some recommendations on innovations in this very difficult area of service provision. I think you'd agree we need to do better. We need to improve our patients' experiences and outcomes, and any suggestions will be gratefully accepted. The second area of focus that I would like to discuss is what we're referring to as optimised pre-surgical care. Why do we think we should optimise all patients undergoing elective surgery? If we can help prevent surgical complications, improve our patients' outcomes, and reduce costs to the health system, why wouldn't we do it? We also know that good optimisation may even lead to surgery not being required. There is good evidence for this in knee arthroplasty and anti-reflux surgery, to name just two. Another way of looking at this is to draw a parallel with pregnancy, during which women are expected to participate in a structured antenatal care program. Why shouldn't we do the same for a significant event such as elective surgery? We also know that we'd all prefer to operate on patients like these, as it would make our lives a lot more straightforward. But we constantly see patients presenting to outpatients and to hospital for surgery in a non-optimised state, and may also see potentially avoidable complications. When discussing surgery, patients are often told they'll need to address certain areas prior to them being approved for surgery, or that their comorbidities will impact on their outcome. Patients understandably complain, well, why wasn't I told about these issues while I was waiting to be seen? They may have been waiting anywhere from 2 weeks to 5 years for an outpatient appointment, and then can be waiting again up to 5 years for their surgery. As for what conditions we should be looking at optimising, the list is long and varied, but commonly includes weight, diabetes, smoking, alcohol, frailty, cardiovascular and pulmonary fitness, musculoskeletal strength, and anemia. In addition to these will be more specific conditions that may be impacting on each individual's readiness to achieve the best possible outcome from their elective surgery. When I've spoken with many people about this over the last few years, they often say, it's a no-brainer. My response to them is, well, if it's a no-brainer, why don't we do it? There are equally many different ways to achieve optimisation prior to surgery. A multidisciplinary approach involving both community-based and hospital-based interventions will be required to a greater or lesser extent, depending on the needs of each individual patient. Certain components that could be utilised include a surgical school, similar to antenatal classes, online education resources, allied health input in terms of dietetics, physio, exercise physiology, and should also include psychology and pharmacy pain education. A perioperative physician, high-risk anaesthetic service will also be necessary for particular targeted interventions. Inclusion of the patient and their GP in their individual optimisation plan is essential for ongoing motivation and monitoring of progress. So, we decided to look at a patient's surgical journey and see where we could make a difference. Consider the entire patient journey as optimised surgical care. In fact, it was recognised that there are many points along the patient's surgical journey that are available for optimisation interventions. Peri-op and post-op periods have been addressed relatively well already, but not so the pre-surgical time period. We have chosen to focus on that time from when the GP makes a referral to a specialist in a hospital outpatient department through to the time of the actual surgical procedure. The network has developed in conjunction with input and feedback gained from many sources, including a recently convened statewide optimisation workshop, a framework for optimised pre-surgical care. Optimisation during this period is currently done in an ad hoc fashion with pockets of excellence across the state health system. Our goal is to enable all patients access to, and the expectation to be included in, a program that helps deliver them to their surgical procedure in an optimal condition. The network feels that we need to change the paradigm and heighten the awareness of both healthcare workers and our patients as to the significance of an elective surgical procedure on their well-being and the potential impacts of improving their health prior to that procedure. To get the program up and running, so to speak, the network is keen to set up 4 pilot programs across South Australia and to evaluate the effectiveness of our proposed framework. We hope to have these started, subject to accessing necessary funding in the near future. The final area of focus for the network that I would like to update you on is one very dear to the hearts, or should I say bowels, of many patients and clinicians across South Australia. Last year, I saw a compelling presentation about a program called SCOOP, which is the Southern Cooperative for Prevention of Colorectal Cancer. This was instituted 20 years ago in Saarland to improve the accuracy and outcomes for patients being followed with surveillance colonoscopies due to an increased risk for colorectal cancer. I couldn't understand why there wouldn't be a similar program available to all patients across South Australia and Australia for that matter. After discussions with the SCOOP team, the network was once again able to gather medical and surgical gastrointestinal leaders from across metropolitan and regional South Australia to meet and discuss the current issues facing colonoscopic surveillance in South Australia. We agreed upon a goal for the group and asked the CEIH to undertake a current state mapping of surveillance. Many areas of variability were found. In particular, significant differences were discovered in the areas of program access and retention, booking processes, platforms used to record and access patients' clinical information, and adherence to current guidelines for surveillance intervals. To look further at 3 of these, it can be seen that no site has the perfect application for accessing clinical information, linking to an EMR, or automating mundane clerical tasks. As for the possibility of gaining access to statewide data for research purposes, this is currently impossible. Also, there are multiple areas of variability when it comes to the actual framework or protocol for the surveillance programs themselves. Who's included? How long for? Whose responsibility is it to ensure the recall actually occurs? Who ensures communication of histopathology results? Of more concern is the current variability in auditing of adherence to surveillance guidelines. This may well be due to the time-intensive processes required as a result of the lack of automation of these processes. Experience has shown that without rigorous independent review of surveillance recommendations, we can be doing up to 40% of procedures and they may be undertaken at an inappropriate interval. This can lead to an increased risk to the patient from both too frequent or too infrequent colonoscopies. It can also lead to an increased cost to the system and then a decrease in the number of index colonoscopies that can be undertaken as well. Just froze there for a second. There is currently a funding grant application being assessed, which we hope will enable us to make progress on the development, implementation, and evaluation of a groundbreaking and long overdue surveillance colonoscopy optimised prevention via an e-system or SCOPES program that can be rolled out across multiple sites in South Australia. We actually have interest from potential collaborating sites interstate as well. The potential for research from this expanded data set is significant. But importantly, the surveillance program a patient has access to will no longer depend on their postcode, and I'm hopeful that we'll have more to report on this in the near future. So in summary, I hope I've been able to pique your interest in a few areas that the statewide surgical and perioperative care clinical network see as important for the delivery of excellent surgical care to our patients. As is often the case when one is trying to introduce new ideas or change existing paradigms, I'm often left asking myself this age-old question. I'm hopeful that with innovative thinking and hard work, we may be able to find ways to succeed in this notoriously difficult task.